I've turned the recording on. And will be made available on CPH's website to members, and then more broadly after a couple of months. So, if speaking of our conference, if you are interested in receiving updates about the conference or about anything that the association is doing, there's a number of ways you can do that. If you check out the link that I've provided in the web box, in the chat box, you can stay connected through a number of different newsletters that we have available for us. So, without any further ado, it's my great pleasure to introduce Dr. Trevor Hancock, today's speaker. Dr. Hancock is a public health physician and health promotion consultant, and is currently a professor and senior scholar at the School of Public Health and Social Policy at the University of Victoria. His main areas of interest are population health promotion, healthy cities and communities, public health, healthy public policy, environment and health, and healthy and green hospitals. So he really has very few interests as far as I can tell. For more than 30 years, Trevor has worked as a consultant for local communities, municipal, provincial, national governments, healthcare organizations, NGOs, and the World Health Organization. He was made an honorary life membership of CPHA in 1990 and an honorary fellow of the UK's Faculty of Public Health in 2015. In 2017, he was awarded the De Vries Medal, CPHA's highest award, presented for outstanding contributions in the broad field of public health, as well as he has also received a Lifetime Contribution Award from Health Promotion Canada. His volunteer work at CPHA he led the development of a comprehensive discussion paper on the ecological determinants of health, and was an external reviewer for the Rockefeller Foundation Lancet Commission on Planetary Health. He is now leading a series of local conversations on the concept of Victoria as a one-planet region, and is endeavoring to have the University of Victoria explore its role in addressing the issue of the Anthropocene. He was also appointed as a senior editor to the editorial board of the Canadian Journal of Public Health in 2014, and in 2015 he was invited to join the editorial board for a new journal, Cities and Health. Since 2014, he has written a regular weekly column on population and public health for the Times Colonist, the daily newspaper in Victoria. Welcome, Dr. Hancock, and I turn the microphone over to you.
Thank you very much, Ian, and good morning, everyone, or I guess if you're in Ontario or further east, good afternoon. I'm going to talk about this. What I was asked to do was not so much to talk about a day in the life of a public health professional, but a career as a public health professional. I've been in this business now for coming on 40 years, and I've picked up a few ideas along the way. And as you'll see, my title here, Passion and Serendipity, pretty much describes my career. So let me move on and into this. So I'm going to talk about serendipity, just being in the right place at the right time by good chance. Passion, politics, and principles, which are three things that have sort of driven my career in many ways. And then my career path, which, as I will make clear, really wasn't a clear path, but more like a kind of ramble along the pathway. And as things came up, I followed a different path. And then I want to have a second part where I talk about my thoughts on public health in the 21st century based on my last 40 years of working in this area. So I think a key point here is that I can tell you what I did and what I learned, but I don't know whether it'll work for you, and I don't know whether the way I approach public health is going to work for you. But I can tell you what I did, and hopefully there'll be something in it that you can take away. So let's start with the serendipity. Serendipity is described or defined as the occurrence and development of events by chance in a happy or beneficial way. And I've had a lot of happy occurrences along the way. So probably one of the more important things in my life was the year I spent after high school, between high school and medical school, because in Britain, where I trained, you went straight from high school into medical school back in the 1960s. But 1966, 1967, so more than 50 years ago now, I spent a year as a volunteer teacher in Sarawak in North Borneo, in a small community, and it really changed my life. It changed it in ways that I certainly didn't understand at the time, and took me years, decades even, to really understand how important that was in my life. But I guess the point here is, if you have an opportunity like that to take a chance and be adventurous, do it, and do it young and early if you can. Second thing is that I was in medical school. I went from Sarawak straight back into medical school in London. But because, as I'll talk about shortly, I was also really at heart a naturalist, I ended up reading a new magazine that had just started in the late 60s called The Ecologist. And that journal in 1972 put out a document called Blueprint for Survival to support the first UN conference on the environment, which took place in Stockholm in 1972. And it called for the establishment of an ecological politics on the grounds that none of the current political parties were really addressing the ecological crisis that even then we were facing. So that made sense to me. And so when I was doing my intern year, I also was an area organizer for what was at that point called the People Party. We're talking here 1974. And I got involved in that. And that's also where I started getting involved in futurism, because one of the people that I was working with in that organizing work was also involved in futurism. And so that was another sort of serendipitous thing that sparked my interest in the way I went. And then in 1975, after my intern year, came to Canada and went into rural family practice in New Brunswick, actually, which I did for about 18 months. But just about the time that I arrived, just before I arrived in Canada, the Lalonde Report was published, and somewhere I still have my original dog-eared, much marked up copy of the Lalonde Report from back then. And I read that, and that also changed my life. It made perfect sense to me, given my broad understanding even then of health. So then in 1978, after a couple more years in family practice in a community health centre in Toronto, and I worked in a community health centre because I really don't like fee-for-service practice. I think it's a lousy way to train, to pay doctors and to practice medicine. And I wanted to work on salary in a community health centre, so I did that for a couple of years. But then really felt I was constantly sort of patching people up from a battle and sending them back into the battle, but not stopping the war. So I decided to go into public health, and it happened that 1978 was the first year of the new, actually I've said MPH, but it really was the MHSC, the Master of Health Science program at U of T. So I was one of the guinea pigs for that first year of moving from what had been a 9-month diploma in public health to a 2-year master's. So again, sort of stuff happened around me, but at the same time, when these opportunities present themselves, you have to grab them. And then my first job, so I supported myself having stepped out of family practice. So 2 days a week I worked for Peel Region as an epidemiologist while I was doing my master's degree, and I'm very grateful to Peel Region for supporting me at that time. Particularly since I didn't then go on and work for them, which I know is what they had expected and hoped I would do. But the medical officer of health there at the time, Bob Appleford, gave me a copy of a new report that had just come out called Public Health in the 1980s from the City of Toronto, and asked me to review it for him and give him a report on it. And I was just entranced. I loved what it had to say. It was totally in tune with my own thinking, and I couldn't wait to get to Toronto, which is what I did as soon as I graduated, and worked in something called the Health Advocacy Unit, which is a brand new unit set up to be a sort of radical public health group within the city of Toronto. And we had a great deal of fun and hard work and really quite a political approach to public health in those early 1980s in Toronto. And then along came 1984, which, as it says here, and you can read for yourself, a whole bunch of anniversaries all coincided. Nothing like a bunch of coinciding anniversaries to seize the opportunity to get money, which we're able to do. And so I organized a conference. It was the first conference on healthy public policy, and we had lots of budget. We were able to bring in good speakers from around the world and launched the idea of healthy public policy. And at that same time, we'd already started to think about, in the health advocacy unit and in the city, making Toronto the healthiest city in North America. That was the mission statement that I had helped to develop when I was the health planner in the health advocacy unit. And so we started to ask ourselves, well, if we were going to be the healthiest city in North America, what did that actually mean, and to be a healthy city, and how would we get one? And so we, at the same time as that Healthy Public Policy Conference, organized a one-day city workshop called Healthy Toronto 2000, and that sort of launched the Healthy Cities idea, and that was picked up by Ilona Kickbush and Ron Draper. The idea of healthy public policy was incorporated within the Ottawa Charter. Healthy Cities was actually launched in January of '86 in WHO Europe in Copenhagen. And so by 1986, I had all these other people who wanted a piece of my time. And I remember very clearly my boss, Sandy McPherson, the Medical Officer of Health for Toronto. By then I was an Associate Medical Officer of Health since about 1982. Basically saying to me, well, it's all very well that the Faculty of Environmental Studies at York University and Ryerson and WHO want part of your time, but when do you work for me? And so what I decided with him was that I would quit the department and become an independent consultant, and he would rehire me 2 days a week, and then the other 3 wanted me 20% of my time, and so I went into consulting with 100% of my time spoken for. That was quite a big step. It meant giving up the security of a salaried job, the security of pensions and paid vacations and all the other things that come with that. And oddly enough, it made me a fee-for-service public health physician. So quite unintentionally, I ended up back in fee-for-service, but in a very different context, of course. So those are some of the things that happened to me kind of along the way. But as I say in this slide, good luck is not enough. You need to recognize it. So you need to recognize an opportunity when it presents itself. And I think part of the problem is people don't recognize opportunities. And then you have to be willing to capitalize on it. And that means taking a plunge. After I stopped being a family doctor, the next 2 or 3 jobs in a row that I took paid less than the one before. So I was following my passion, but not necessarily being financially responsible. But you need to be able to take some risks, I think, in life. And that's where the passion comes in. And my passion was based on a set of principles, which I'll come to in a minute, and a sense of adventure. You know, the fact I went off to Sarawak indicates that. Going off for me as an 18-year-old in London, the unknown. Curiosity, an inquiring mind, you never stop learning. There's an old saying that education is wasted on the young and retirement is wasted on the old. And I think that's a great way of looking at it. I have no intention of stopping learning. And then a holistic way of thinking, that you have to be able to, I think, in public health in particular, recognize all the different pieces, connect all the dots, recognize the pattern that connects. That's the business that I think we're in public health. And so I talked at the outset, this section was about passion, politics, and principles. So what about the politics? Well, as it says here, it came primarily out of my analysis of the state of the world, having been reading The Ecologist and then getting involved as a result in this new and radically different political approach of green politics. So the People Party became the Ecology Party, became the Green Party. And I was actually there in 1974 at the founding convention for all of that. But I also brought, in addition to my ecological analysis, I brought a concern with social justice, both from my Sarawak experience and particularly my family practice experience, both in rural New Brunswick, which was a fairly fairly poor community. I mean, not desperately poor, but not all that well off. And certainly from working in a community health centre where as a community health centre, about half of our patients were on some form of social assistance. And so that in particular surfaced my concerns around social justice. And so that led me, when I did my master's, to use my major paper to identify my principles for public health. And I published a paper in 1981 based on my major paper for my master's program, in which I identified my key principles. At the time, I called it ecological sanity and social justice. Today, we'd say sustainability and equity. But those two key principles have really guided my practice for almost 40 years. And I think it really helps to have clear principles as to what business you think you're in and what your principles are that you're going to found your career on. I wouldn't say they have to be my principles, but it's important to sort out your own fundamental principles. And then as I look back, I would say that I missed a couple. I missed peace and participation in particular. And I certainly, if you look at the Ottawa Charter for Health Promotion, for example, the first prerequisite for health is actually peace. So, and actually, incidentally, the Ottawa Charter was the first WHO document that identified what I've called here ecological sanity as a prerequisite for health, recognized sustainable resources and stable ecosystems. So those are my fundamental principles. And I guess just to close off this first part of my presentation, I would challenge you, what are your fundamental principles? What are the guiding principles for your life and your career? So that's kind of part one about how, in some ways, how I ended up doing what I'm doing now and have been really for the last 40 years, relatively consciously. So let's talk about my career path. As I said, it wasn't really a path in the sense that I knew where I was going. It was more like a ramble, and I took side paths as I went along. I never really had a career plan. In fact, I really don't believe in them. And that is even more the case in this day and age when change is so rapid and everything is so much more fluid. I always took a job, as I said earlier, because it sounded interesting or fun or challenging or all three. It sort of spoke to my passions. And as I said, it often meant making less money, but money wasn't what motivated me. It was following my values, my passions. Clem Bezold, a very good friend of mine and one of the world's great futurists, said years ago that vision is values projected into the future. So another way to understand what your values are is to think about what your vision of the future is, or vice versa, to be clear about what your values are, and then say, well, if society enacted the values that I hold, what would society look like? And that's the vision that you're working towards. I never held a job more than 9 years. The longest time I ever worked for any one organisation was the 9 years I worked for the Ministry of Health here in BC between 2002 and 2011. And I think really importantly, the next thing I did was never what I thought it might be when I went into the job. So I thought when I went into the job at the City of Toronto, I would be there and I would eventually be perhaps the Medical Officer of Health for Toronto or some other area. None of that happened. Other opportunities came up. So for all those sorts of reasons, I really don't believe in career planning. I believe in being open to opportunity and seizing them and following your passion based on your principles. I began in medicine. I am a physician by training. I'm a public health physician. But actually, I really thought I'd be a naturalist, or I was a naturalist as a young school boy. And I thought maybe I'd make documentary films about nature and be inspired by people like, David Attenborough and people like that. And actually, my first career wasn't really medicine. It was teaching. And in a sense, I've never really stopped. I've been a teacher since 1966 when I started teaching in Sarawak in a junior high school. And as I've already mentioned, I felt, family practice was fine. I didn't leave it because it wasn't fulfilling, but it was that public health was even more attractive, even more exciting. And so I moved on. I've always moved on to what I find exciting. And of course, if you practice public health, I think in many ways you have to unlearn medicine, perhaps unlearn nursing too. You have to and graduate instead to health. And so you have to learn, you have to be a lot broader in your thinking. You have to understand the social sciences, anthropology and community psychology and sociology, the natural sciences and the design science professions, design disciplines, so architecture, engineering, landscape architecture, urban planning. You certainly need to understand in this day and age ecology. And then because you're working in the public sector, you have to understand public policy and public administration and communications. So this is actually much more complex and much richer than medicine. And that, in fact, is why I think that public health is the most exciting and challenging and difficult specialty in the health sciences, whether you're in nursing or in medicine or in nutrition and dietetics. And actually, that is the title of the first of a series of columns I've been writing for the last 6 months or so for the Canadian Medical Association Journal. That first one was called Why Public Health is the Most Challenging Specialty of All. And I've written 5 other columns, 4 of which are now published. So I've got 5 published altogether. There's a 6th one in the tubes and a 7th one and last one I'm about to write. So I've been trying to explain public health in the 21st century for the medical profession. So you might be interested in checking those out. So let me then move on and talk about some key issues and challenges that I think that you, particularly as emerging young professionals in public health, some of the challenges and issues you're going to be facing. And let me begin with the public in public health. We are the public. And what does that mean to be the public? For one thing, it means it's a collective sense of the people. The Ottawa Charter talks about health promotion as the process of enabling people to increase control over and improve their health. But people in that sense is both people as individuals, but also people as the people, the community. And certainly in public health, we sometimes public health medicine is sometimes called community medicine. And public health nursing sometimes called community nursing. I think they're different actually, but particularly in terms of their clinical approach. But we work in and with community, and our quote unquote patient, although we don't have patients, which is another distinction, but our quote unquote patient is the community. But secondly, when it says the public in public health, we work in the public interest. We are there to defend the public interest, to defend a public good, and that public good is the health of the public, the health of the population. So we work in the public interest. And what that also means, and it's an interesting one because most of us work as civil servants, is we do not work for the party in power. We are not political servants. We are public servants. We work for the public. And I think that's sometimes a difficult line with ministers and senior bureaucrats to make that distinction. But I think it's a very important distinction that public servants are working for the government and technically for the crown, for the state, not for the political party that happens to be in power at this moment. And obviously you have to kind of balance that off, but I think it's important to keep that in the back of your mind. We work in the public interest, we work for the public, and a final aspect of public I think we need to explore and understand is public inevitably means public policy. That we are in the business of formulating or managing or enforcing, or in some cases opposing, public policy. And that makes it political, not necessarily partisan, although clearly if you have a collectivist understanding of health and of society, that puts you at one end of a political spectrum. So, but that isn't the same as being big P party political partisan. So we're not, and we shouldn't be, as public servants, partisan per se. That brings its own tensions, which I'll come to in a minute. A second really important issue, and it worries me sometimes that I hear people expressing the opposite of this, the notion that somehow we should be neutral. That as quote-unquote scientists, we should take a neutral position. We shouldn't be advocates. I think that is absolutely, totally and utterly wrong, and in fact a betrayal of public health. We're not neutral. We are very clearly biased. We are biased towards health. We are in favour of health, and we're opposed to anything that harms health, whether that anything is a public policy or a private corporate activity or the activities of individuals. But if it's harming other people's health, we're opposed to it. And it doesn't matter who the party is, or whether it's the government or whether it's a major corporation. We're opposed. We're not neutral. And in fact, I would say if we're not ruffling feathers, we're really not doing our job. We have been, if you like, fighting the merchants a long way back. There's a wonderful little book by Carlo Coppola, published about 1976, on medicine and public health in the Renaissance. And he looks at the Renaissance Italian city-states, and he has wonderful observations in there about how the public health officers for the boards of health, because those city-states had boards of health, they were some of the first boards of health in the world back in the 15th, 16th century. The public health officers there were complaining about the merchants, because the merchants didn't want their goods quarantined to prevent or their traders quarantined to protect against the spread of infectious disease. And of course the merchants complained that the public health officers were overreaching themselves in protecting public health. So we've been, if you like, fighting the merchants of illness and disease and death, for 500 years, 600 years. If we're not doing that, we're really not doing our job. And the third point about being neutral is I don't respect someone just because they're the minister or the premier or the queen or the professor or whatever. You don't get respect from me just because of your position or status. You need to earn my respect. And it's based on your ability, your values, your actions, your own principles. So I'm not going to support you just because you're the premier or the prime minister. If I think you're being an idiot, I may not say that to you, and I may not say it in public, but I will find ways to either express that in my actions or my inactions. You can do a lot by doing nothing sometimes. Which takes us into the realm of advocacy. This is another major challenge in the 21st century. And it's something that actually has been troubling us. If you saw the recent editorial that I wrote on behalf of the editorial board for the Canadian Journal of Public Health, and it's on behalf of a group of us who are working to protect what we see as the erosion of public health in Canada right now. And one of the areas where we see that erosion is in the restriction of, in particular, public health physicians as medical officers of health, but also public health in general, restrictions on the ability to speak out, to be advocates. Health authorities don't like upsetting ministers and So they don't want their public health officials out there causing trouble and being advocates and being outspoken. I think it's a betrayal of what public health is about on the part of the health authorities, but also ministers and ministries don't want it either. So advocacy, it becomes difficult. I wrote an editorial about that for the Canadian Journal of Public Health a couple of years ago now. Advocacy, it's not a dirty word, it's a duty. And of course, remember, it's actually a core public health competency in Canada. It's in the list of core public health competencies. So we need to be advocating. We need to be expressing our point of view in defense of the public's interest, in defense of the public's health, expressing our bias pro-health and anti-pathogenesis, if you like. The other thing, and that particularly is the case when it comes to my engagement in politics, which I haven't been active in politics for a number of years now, but I didn't stop being a citizen when I became a public servant. You need to be able to draw a bit of a line between those, but I think what I do outside of my 9-to-5 job, I'm not a public servant 24 hours a day, 7 days a week. If they want me to be that, then they need to pay me 24 hours a day, 7 days a week. Otherwise, outside of my job, I'm a citizen and I still have the rights of a citizen. And I think we need to, obviously that's a tricky balance to play. But I managed, for example, to run for the Green Party in 1984 in the federal election while still working full-time for the City of Toronto, because I campaigned evenings and weekends, and I made the point that this had nothing to do with the City of Toronto. It wasn't about city politics, it was federal politics. And they accepted that. The other way, though, that you can do this, which is a lot less controversial than being actively engaged in politics, is to join professional organizations such as the CPHA or other NGOs. And again, sometimes just joining them by paying your membership so that you support them. I've been for 30 or 40 years a member of the Non-Smokers' Rights Association. I think they've been one of the outstanding associations or activist groups for health in Canada and indeed in the world. I haven't done a lot for them other than pay my dues, but I've paid them for the last 30, 40 years. And you can do that. You can get actively involved, as I have done with CPHA and OPHA, and been president of OPHA back in the day, in the 1980s. Or you can found one, and I've done that 2 or 3 times. I co-founded the Canadian Association of Physicians for the Environment, co-founded the Canadian Coalition for Green Healthcare. So there's lots of ways that you can be active and engaged outside of and around as well as within your job. But advocacy is one of your duties. Third thing I'd say is just keep asking why. And some of you may know Jason's story. If you don't, check out the second report on the health of Canadians. And if you get the PowerPoint, I actually have it in the slide notes. I don't think you get the PowerPoint in this process, but anyway. You keep asking why, and every time you ask why, you go further and further upstream. So why is Jason sick? Because. Well, why did that happen? Because. Well, why did that happen? Because. And so on. So going upstream, keep asking why. Why? And as I say, check out Jason's story, which is a lovely little way of encapsulating that in the second report on the health of Canadians. So let me end by talking about what I see as 3 key challenges for public health in the 21st century, and therefore for you, as well as for me. And I've encapsulated it these days as people, planet, and participation. You'll recognize in there really social justice, ecological sanity, and participation, of the principles I talked about earlier. For me, when it comes to people, it's about socially just human development. I've always liked the WHO slogan from the 1970s of health for all. Not health for some or health for a few or health for many, but health for all. And how do you achieve that? How do you achieve socially just? And notice I say human development. It's not just health. It's a broad concept of health as physical, mental, and social well-being, as really human development. Secondly, the second challenge is around planet. I think very clearly we are facing an ecological crisis. It's been sort of encapsulated now in the concept of the Anthropocene. The challenge is we have one planet, but we're living right now in Canada as if we had 4 or 5, and we don't. And that has to change. We have to actually reduce our ecological footprint by 80% fairly quickly. And at the same time, we have to maintain good health for people. So that's the public health question. How do we shift to a one planet way of life while at the same time maintaining or indeed perhaps improving health? And then the third principle is around participation and engaging all stakeholders equally. So how do you engage? And we generally need to be on the side of the powerless or the less powerful, and working with them. How do we negate the influence of money and power in decision making? How do we engage all stakeholders equally? And what does that look like in the digital age? The model of democracy we have now evolved basically in the 19th century. It was suited to the 19th century. It's really not fit for purpose in the 21st century. How do we reimagine participatory democracy in the 21st century? And at a local level, you can do much more than at a provincial or national level at this point. So we as public health should be engaged in things such as participatory budgeting, participatory decision making, digital and electronic democratic engagement. Some really interesting challenges there, not just for public health, but for governance. And one of the things I talk about a lot, these are 3 principles that I often talk about in the context of governance for health. How do we govern ourselves as communities, as a society in the 21st century in a way that creates socially just and ecologically sustainable human development for all? That's, I think, the business we're in. I'm just going to very quickly point to 3 examples of that. I'm not going to dwell on these. So this was a statement came out of what was it called? It was an urban think tank that was organized ahead of the UN Habitat Conference a couple of years ago. There were a number of these around the world, and this was one that I was engaged in, the only one actually that focused on health. And we came out with a statement on people, planet, and participation. You may recognize the terms there. So you can find this. The statement was actually published in Health Promotion International in, I think, 2016. And it talks about our need to understand urban development in terms of complex interconnections between ecological, economic, and social foundations. So you might want to take a look at the Kuching statement as an example. I'm going to skip through this. And then much more recently, just a couple of weeks ago, 13th of February, a statement came out of the WHO Europe Healthy Cities initiative, where they brought a whole bunch of mayors, about 40 mayors from across Europe together, and came up with a consensus statement on healthier and happier cities for all. And I just want to stress their 6 Ps are their principles in here, because again, you'll recognize a common theme here. Investing in people, designing urban places, ensuring greater participation, improve prosperity. Now, prosperity in this context means ecologically sustainable, socially just prosperity, has to. Promoting peace and protecting the planet. So they have this set of 6 Ps, and I would submit that these are really, these 6 Ps are sort of key challenges for public health in the 21st century. People, places, participation, prosperity, peace, and planet. And if you can't have fun pursuing those objectives in the next 20, 30, 40 years of your career, then you're not the right person in the right place, because this is where it's at, folks. Anyway, that's it. Over to you.
Great. Thank you so very much, Trevor. What a thought-provoking presentation. So we have one question in already from Kathy Gladwin, who wrote, what are the biggest threats for the health of Canadians due to ecological degradation?
Okay. Well, I would say read our report. For starters, CPHA discussion document is on the website. There is a background document that's also there, which is 100 pages or so. We identified a whole set of challenges. Certainly the biggest one right now, I would say, is climate change, and that is both regional, national, and global. And climate change is having obviously severe weather events and climate changes, the challenges of drought on the prairies and what that might mean for the crops we grow, the impact of severe weather events, the spread of insect-borne diseases, and then what it does globally and how it affects global security. I'd say the other profound challenges we face is resource depletion of fisheries in particular. We have pretty much fished out the oceans, or are on our way to doing so. The loss of farmland to erosion and salinization and just general degradation. We're degrading farmland at an alarming rate around the world. And some of those key resources like that, water in some places for sure. So really resources that affect our ability to feed ourselves in particular. Pollution, and we hear a lot about plastics pollution, but there's also ecotoxicity. The fact that all of us carry a body burden of persistent organic pollutants, and we have no idea what the health impacts of that are. And then the most profound challenge, but the one most difficult to quantify in health terms, is the loss of biodiversity. So we have initiated a sixth great extinction. And the problem is when you have great extinctions, you don't know which are the keystone species that if you damage them, you damage and disrupt entire ecosystems and ecosystem webs. So very, very troubling. And really, the biggest challenge is actually that it's all of those and more. I haven't mentioned ocean acidification and disruptions of geochemical flows and so on, disruption of the ozone layer. And the real challenge is that all of those things are happening simultaneously and often interacting. So read the report.
Great, thank you, Trevor. Now we have a question from Akangabi Guillaume. There's a bit of shorthand in here, so I'll try to get this right. Public health work within ministries is complex and has many inherent constraints due to the proximity to provincial politics, strong public service, which is neutral, and a non-advocacy ethos. What have been the most surprising, exciting public health successes you have witnessed while working for the Ministry of Health?
Hi, Akangabi. I should tell you that Akangabi is one of my partners in crime on a lot of this work to resist the erosion of public health in Canada, and she's also published editorials and commentaries in the Canadian Journal of Public Health about this. Before I get specifically to the point about what I've witnessed at the ministry, I think that, I mean, you're right about the inherent constraints due to proximity to provincial politics. And I think we might want to think about other ways of organizing public health, particularly at a senior level. So, for example, maybe the chief public health officer for a province should not be within the Ministry of Health, but should be more in a position like the Auditor General, where they are reporting to the legislature, not to the minister, and reporting therefore to government as a whole in a more sort of auditor general type function, so they could report on the public health impacts of public policies as well as private policies. So we might want to think of them more in that role, more like we have a Commissioner for Children and Youth, for example, who's played that role. And they can be much more adversarial. I mean, that brings with it its own challenges. But I think we need to think about how you protect the voice of public health and its ability to speak out. And I don't think right now it's working at all. So we might want to look at alternative models. Now, whether government would go along with that, I doubt it, because they really don't want those kind of watchdog roles watching them. But just because they don't want it makes me think it's probably a very good idea to have it. So we want to think about that. In terms of public health successes, maybe not so much working for the ministry, but I think that the work we were able to do in the 1980s against tobacco, where there was strong support from the federal government, from provincial governments, and in particular from municipal governments. And in my experience, most of the successes that we have often start at the local level, and not just in the area of public health, or public health broadly understood. So you get municipal governments, for example, committing to paying a living wage or encouraging a paying of a living wage ahead of provincial governments doing that. Municipal governments have been leaders on climate change action compared to provinces and the federal government. Certainly on tobacco, they were passing bylaws and taking action ahead of the government. In terms of what I witnessed working for the Ministry of Health, because of the kind of work I was doing, the successes were more within sort of standard public health work around core public health functions and so on. But I think that if I look at the work of Perry Kendall and the province as a whole in addressing health inequalities for Indigenous people, and the way that Perry and others in the population public health branch were able to really begin to address the public health challenges of First Nations in BC, and to raise issues of inequalities in health and push that agenda. And of course it was being pushed, of course, by the First Nations themselves, but the ability to collaborate around that, I think that's probably one of the more dramatic successes that I've seen in terms of helping to change the agenda. And it was obviously part of the trick is you have to see where the opportunities are and exploit them again. And that was clearly one. So I hope that helps a bit.
Okay, from Finola Hackett, how can these key public health principles be incorporated into the day-to-day clinical work of health professionals such as physicians? I'm a medical student with a keen interest in integrating social justice and ecological sustainability into my future practice.
Okay. Well, I guess it depends where you end up in terms of practice. But if you're within the healthcare system and working as a clinician, as a specialist, or as a family physician, but particularly if you're working within the hospital and health authority sector, one thing you can do is to support the greening of healthcare. So I mentioned earlier I helped set up the Canadian Coalition for Green Healthcare, which continues and is very active and has done a great deal of work, and there's an international, a global movement around this, to bring attention to the fact that the healthcare system is, in environmental terms, a bad actor. We are energy pigs. Hospitals are some of the most energy-intensive facilities in your community, second only to industry. We keep large spaces at a constant temperature, regardless of outdoor temperatures, 24/7. We use huge amounts of disposables, a lot of it probably unnecessary. a colleague of mine did the ecological footprint of Lionsgate Hospital in North Vancouver, 15 years ago now. And that one 500-bed hospital in 1 year went through something like 1.25 million pairs of disposable plastic gloves. And 95% of them are not used for sterile purposes. So we need to be rethinking our use of disposables, our use of energy and so on, the use of chemicals and pesticides, which is also an occupational health hazard. So there's a huge amount you can do around greening your own office, greening the hospital. And then there's a whole set of issues around social justice that you can look at. So who is it that does not have equitable access to healthcare, necessary healthcare services? Who, for example, doesn't get pap smears or mammograms or colon cancer screening or immunizations or any of the preventive measures that we're particularly interested in, but generally doesn't get access to proper healthcare. And we know who those people are. Partly it's geography, partly it's culture, partly it's income and education. And of course, the really interesting challenge there is that people who are living in poverty have worse health. So it's not that they need equal services to everybody else. They actually need more services per capita than anybody else. And so we have a sort of double inequity. Not only do they usually have less access, but even if they got equal access, they still would be suffering inequity because they actually need more services on average. So what does your hospital or health authority, or for that matter, your practice, do to redress those inequalities in access to services? So that's what you can do just within the healthcare system itself. And then, of course, if you go into public health, there's all sorts of things you can do regarding social justice and ecological sustainability in the community. The Health Officers Council of BC, of which I'm a member, has been very strong for many years on anti-poverty work, on standing with groups like, what's it called? Not Health 2000, but it's the Advocacy Coalition for Ending Child Poverty. And we have stood with them, attended press conferences, spoken out, put out position statements and documents, pushed the government as hard as we can to address inequalities in health. And clearly we have to do the same thing. And again, that's why you join NGOs and professional organizations. So even if you couldn't do it within your day-to-day job because it would put you at risk in some way of discipline or of firing, or even worse, what they actually tend to do is they get at you by cutting the funding to your office or your program or your agency. So you can get together with your colleagues and be somewhat more anonymous and still speak out that way. So those are some of the things.
We have just 3 minutes left, and we have a question that will take much longer, but from a young up-and-comer, Donald Sutherland. Do you think the Public Health Agency of Canada has been effective? And if not, why?
I think the Public Health Agency was very effective in its first few years. It got defanged by the Harper government. Regrettably, it's not been restored by the Liberals. I don't really understand why the Liberals aren't supporting this agency that they themselves created. So the Chief Public Health Officer is no longer the President, but is really more like an advisor to the President of the agency. And the President is a career civil servant, I think, with, I'm not sure about the current one, but with no public health background or experience. It's been cutting programs. It's cut the awards for practicums. It's cut public health online. I think it is failing at this point. And what I really don't understand is why the Liberals, under their watch, have not sought to repair the damage that was inflicted by the Harper government. So right now, regrettably, I think it is not working, and it's not working because it's lacking in the political understanding and support that it requires.
Excellent. Thank you so much. Unfortunately, we are in the last minute, so that'll have to be the last question that we take. Oh, just under the wire. Okay, very quickly, Paul Graham. Tremendously inspiring and instructive talk today. Thank you, Professor Hancock. Having heard you mention of peace as the first prerequisite for health, and aware that you have a history of advocating against militarism and war, would you support a proposal for CPHA to consider adopting a policy statement to affirm the role of public health practitioners in Canada to advocate for peace? Much appreciated. Thank you.
Well, that's an easy one. Yes. I've not been hugely involved, but I certainly was involved in the 1980s in Toronto. Well, at the time it was called, I can't remember what it's called now, but we did some work particularly about against nuclear weapons in Toronto and published material about that. And certainly as part of a sort of a public health profession, obviously peace is a prerequisite for health. So absolutely, and we definitely need to. But I also think in public health, it's useful to understand peace in a broader context. So I would say non-violence in our communities and domestic violence, racial violence, violence against Indigenous people, and so on. It's all part of peace. So peace isn't just about militarism and war. It's also about civil and community and domestic violence, and we need to be opposed to all of that. And of course we are, and we've been very supportive as CPHA of the Violence Prevention Coalition in Canada, things like that. So absolutely, it's part of our job.
Thank you again very much, Dr. Hancock. Tremendous presentation, and thank you everyone for your questions. Just to pick up on that role of advocacy, CPHA, our raison d'etre is to be an advocate for healthy public policy. Some of the work that is ongoing right now is a position statement on the future of public health that Dr. Hancock referred to. With recent events, we're looking at a position statement on racism in public health. Just with legislation going on right now, we'll be releasing a position statement on nicotine-containing vaping devices, and we're working on a statement on adult vaccination. If you have ideas about position statements CPHA should be working on, and you want to roll up your sleeves and help make that happen, go to our website at the link I just posted in the chat box, and there's a really simple form that you can fill out to suggest your ideas. So thank you all very much for participating today, and again, thank you, Dr. Hancock, for an insightful presentation. Everyone have a great day.